Good afternoon, everybody. My name is Susan Graham, and I'm the director of the Owerko Center. And it's my pleasure to welcome you here today to our fourth annual Owerko Family Distinguished Lecture. Before we get started, I just want to take the opportunity to acknowledge the traditional territories of the people of Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. It's very exciting for us to see such a full auditorium for our fourth distinguished lecture. Many of you have come to support our center in other events like our June conference, and I'm very thankful for that. Thank you for continuing to support us. Before I turn things over to Dr. Szatmari, I'd like to provide a few words of introduction to both the Owerko Center and to our distinguished speaker. In 2014, Stan and Marge Owerko made a very generous donation to the Alberta Children's Hospital Foundation that was aimed at supporting brain health in children. In addition to many other initiatives, their gift was instrumental in establishing this distinguished lecture series and in building and supporting the Owerko Center, which is an amazing research space that we have over in the Child Development Center. I want to thank Stan and Marge personally for their vision, their commitment to increasing children's well-being, and for their very generous support. You've made it very possible for us to be here today. I'd also like to thank the Alberta Children's Hospital Foundation for their support and collaboration in building our center and in providing ongoing support for our research initiatives. For those who don't know, the Owerko Center is a research and education initiative within the Alberta Children's Hospital Research Institute. Our mandate is to focus on training the next generation of clinicians, to generate translational research knowledge, to work with families, communities, and partners to improve the lives of children with neurodevelopmental disorders and mental health challenges. I'm confident that we're making good progress, and this annual lecture is a really good example of this work in action. So now it's my pleasure to introduce our very distinguished guest speaker, Dr. Peter Szatmari, who I think we're particularly thankful that he has come to join us here today in Calgary, because when he left Calgary, or when he left Toronto rather, the other day, it was, I think, 30 degrees. So he went from summer to fall. Dr. Szatmari, summer to fall, ha ha ha. That actually was an unintentional joke. Summer to winter. It's my wishful thinking. Dr. Szatmari is, of course, one of the world's leading researchers and clinicians in the area of autism spectrum disorder. He holds and wears many hats. So he is the Chief of Child and Youth Mental Health at the Hospital for Sick Children and the Centre for Addiction and Mental Health in Toronto. He's the head of the Division of Child and Youth Mental Health and a professor at the University of Toronto. He is the Patsy and Jamie Anderson Chair in Child and Youth Mental Health. So Dr. Szatmari has been a leading edge researcher in autism spectrum disorder for over 30 years. In fact, his career probably started a little bit earlier when at the age of 8 he decided he wanted to be a psychiatrist. He has been engaged in studying autism spectrum disorder from a variety of perspectives, including looking at the longitudinal course of this disorder and its genetic mechanisms. His group has published extensively on identifying genetically informative phenotypes, copy number variants, and along with the Autism Genome Project on linkages and GWASs. He is the founding director of CARN, a patient-oriented research network in early intervention in ASD. He's been the editor of several important journals. He's consulted with government agencies all over the world. He's won innumerable grants, many awards, published more papers than I could count. And in fact, if I keep talking about him, we will never hear about what he has to say. His resume and vita is that impressive. So I'll stop here, and please join me in welcoming Dr. Peter Szatmari.
Thank you, Susan, for that very kind introduction. And let me say how wonderful it is to be in Calgary. The last couple of days, the weather's absolutely lovely here. How you must enjoy this all year long. all this lovely weather. But it's great to be invited by the Owerko Center. What a great center it is. I had a chance to talk about it last night over dinner and learn about what's going on, and looked at the website today, and it's very impressive. It's so important to bring together, to develop these centers that bring together clinicians and scientists and students together doing cutting-edge work. And I know the Owerko Center is doing that and very focused in a significant way. It's very impressive. So I'm delighted to be here, and I'm delighted to talk about our studies and this topic about what exactly is a good outcome that I think is more, I hope you'll agree with me, it's more complex than it might seem at first. So this is financial disclosures, nothing that influences the presentation. So I have a number of objectives. First of all, I want to very quickly review the outcome of autism spectrum disorder in adulthood. I want to highlight some of the blind spots in that literature, and I want to introduce the Pathways in ASD study that was really specifically designed to address some of those blind spots. For the presentation, I'm going to focus on the prevalence, correlates, and predictors of a good outcome, in brackets, and I want to outline some of the clinical and policy implications of that research, and I want to stimulate a discussion about what exactly is a good outcome by reference not only in ASD, but actually to those of you who work in other health conditions. I think this notion about thinking about outcomes is relevant across the health landscape. So a very common question after a diagnosis is given to parents is, how will he turn out? Will he be able to live independently? Will he earn a wage? Will he have a partner? Will he get married? What will he do? How will he live without us? In other words, will he have a good outcome? It's almost the second question after what's the diagnosis. And the third question is what caused it. But the second most question often is, how will he turn out? These are really difficult questions to answer, but they're extremely important ones. So I'm going to just sort of summarize the latest adult outcome studies that were published between 2004 and 2009. And the reason I'm going to focus on these particular studies is because they all use the same scale in order to describe outcomes. So there's a Gilbert study, 2004, Howland from the UK, 2005, Eves and Ho from British Columbia, 2008, and the most recent one, Farley from Utah, 2009. So all these studies use the same scale, combining measures of education, whether they had an independent living, whether they were earning a wage, whether they had friends and were socializing, into this global scale, and divided it up into these different categories of very poor, for example, poor. Christopher Gilbert is the only one that has this category of restricted. That's very typical Christopher Gilbert. Fair, good, and very good. And these are the percentages that fall into each of the categories according to this. So the Gilbert study, almost 60% have a very poor outcome. The Farley study, 24% have a very good outcome. So really the bottom line here is the extreme variability between the different studies. But I think you'd agree that generally speaking, the outcome is either poor or very poor. But I think you can see from the table is that there's enormous variability in the different outcomes. So the range for good to very good is from 0 to almost 50%. That's an extraordinary variation. And while the mean of the 4 studies of a good to very good outcome is 23%, it's not really an informative mean because of the variation in the different studies. And pretty universally, although there's a lot of variability in the outcome categorization, pretty well all the studies agree that the predictors of a poor outcome are lack of fluent language by 5 years of age, or cognitive disability, lower IQ, in other words. Now, just to do a very quick critical appraisal of these adult outcome studies, I think this literature has certain assumptions upon which the studies are based that leads to some blind spots. And one is that there's this assumption that the course is homogeneous, that the individual differences in outcome are quantitative rather than qualitative, and that outcome is a unitary construct that you can think about on a single dimension of outcome, from very poor to very good. Now, the Pathways in ASD study, which I'm going to talk about, was focused on the objective of the study is to look at the outcome of preschool children with autism spectrum disorder into emerging adulthood. And we started out when the kids were 2 to 4 years of age. The kids are approaching now 18 years of age. So we have funding till 18, and hopefully we'll be able to continue to study them into emerging adulthood. And the two basic assumptions that we designed the study on are that, one, heterogeneity is the rule, that outcomes are heterogeneous, not homogeneous. There are qualitative differences. And secondly, that there are multiple ways of considering outcomes, that outcome is not a univariate concept, but is in fact a multivariate concept. The study has been, these are the different funding agencies that have been involved. I'm going to give a particular shout out to the Alberta Innovates Health Solutions for funding the Edmonton site in the study, and the Seneve Family Foundation for their support right from the very beginning of the study. Just mentioned that the Pathways is a patient-oriented research project that we started in the 2000s, really, before SPORE and patient-oriented projects were really de rigueur. Patient-oriented research projects are those in which research participants are actively involved in posing the question, in the design of the study, and in the interpretation of the results. And this really is a paradigm shift in the way research is being done. And more biomedical research now has active patient engagement. And we were able to do this in the Pathway study right from the very beginning. Indeed, we used families, clinicians, policymakers, came up with the research question rather than the investigators. The investigators thought that all the stakeholders would ask us to study the most effective intervention for ASD, and they didn't. What they wanted us to study was, what are the factors that account for a good outcome in autism spectrum disorders? That was quite a surprise to us, but we took the ball, we ran with it, we got funding, and I'm going to share some of the results of that today. So Pathways in ASD is a multi-site inception cohort study. By inception cohort, we mean that the subjects are sampled at the same early stage of their disease. Newly diagnosed children, 2 to 4 years of age, and I'm going to talk about outcomes at 6 years of age and outcomes at 11 years of age. There are 5 sites: Halifax, Montreal, Hamilton, Edmonton, Vancouver. Multi-method, multi-informant, very comprehensive phenotypic battery with a lot of not only child-focused variables, but also a lot of contextual environmental variables as well. So the first sets of results I want to share with you is this issue about whether the course of ASD is really homogeneous or heterogeneous. Are there quantitative or qualitative differences with respect to the different groups of children with ASD as they change over time? I want to focus on 2 developmental trajectories: ASD symptoms and adaptive functioning. Adaptive functioning refers to the attainment of typical developmental milestones in socialization, communication, and activities of daily living. We use the Vineland Adaptive Behavior Scales, version 2, and we're going to talk about the composite score. And most published studies consider symptoms and functioning to be homogeneous domains and highly correlated. That's where we get this idea that higher functioning people with ASD have fewer ASD symptoms, and lower functioning people have more ASD symptoms. So that's a common perception with the way we use the term higher and lower functioning. But actually, nobody has really tested empirically these assumptions about homogeneity and the strong correlation between symptoms and functioning. So this is a brief description of the study characteristics. 421 kids, fairly typical sex ratio. These are the number of kids from the different sites. This is the mean age in months where the kids were diagnosed, and this is the age at which they're enrolled. So we really were able to enroll the children, within a month on average after they had received the diagnosis. So this is really important so that you're not losing kids after the diagnosis for one reason or another. So you can be sure you have a representative sample. For the measure of ASD symptom severity, we use the ADOS, Autism Diagnostic Observation Schedule. There's a severity metric that measures the severity of symptoms, the number of symptoms. And for adaptive functioning, we use the Vineland composite, and I'm going to talk about the standard score, so it's corrected for chronological age. The ADOS is taken at the point of diagnosis, 6 months later, 12 months later, and then when all the kids are 6 years of age. Sorry, the ADOS was not at 6 months, so diagnosis, 12 months, and at 6 years of age. The VABS was taken at 4 data points at the point of diagnosis, 6 months, 12 months, and 6 years of age. The statistical analysis is really important because this really tests the assumption about whether the course is homogeneous or heterogeneous. So we used a technique called PROCTRAJ, which is a semi-parametric group-based trajectory modeling, which basically means we're looking to see whether there are particular clusters or subgroups of ASD kids that have different rates of change over time in these two phenotypic domains. And it's a model testing, it's not hypothesis testing. So you're trying to see which is the model that best, quote, fits the data, and there are metrics for model fit. And we also use parsimony, so you don't want to get overly complicated. We can also look at the cross-tabulation between the trajectories, which I'll illustrate, and then look at the outcomes of the trajectories, and we're looking at IQ, or the Merrill-Palmer, PLS, a measure of language, the Autism Diagnostic Interview, and the CBCL, a measure of internalizing and externalizing behavior problems. Okay, so this is what we come up with the developmental trajectories of ASD symptoms. So here's the ADOS severity metric, here's age over time, and what we find is that there are two groups of kids who have different rates of change in their autism severity over time. The most frequent group, the most common group, is kids, roughly 90%, who have high scores at the beginning, and their scores are pretty stable over time. They're not changing in their severity metric over time. In comparison, there's a second group that has lower scores at the baseline, and their scores drop over time, so that the variation between the two groups is increasing over time. You can test whether actually it makes more sense to think of this as one group of kids, or 3 groups, or 4 groups, or 5 groups. We find that the 2-group model is the best fit and the most parsimonious. So this is what adaptive functioning looks like. In this model, we find that there are 3 trajectories of adaptive functioning that seem to provide the best fit to the data. There's one group who is lower, roughly 30%, and their trajectory is somewhat declining, particularly in the first 6 months after their diagnosis. There's a group in the middle with slight improvement over time, and then there's a third group, which is roughly 20% of the sample that are higher at the baseline. They have a positive trajectory. They have improvement in the first 6 months, and then it kind of flattens out over time. So here, a 3-group model is the best fit for the particular data. And again, I think what you can see is that the variation increases over time, that there's a fanning out of developmental trajectories until 6 years of age. So we've got 2 developmental trajectories for autism severity. One that's infrequent, but that is lower and they're dropping their autism symptoms over time. And another group that's high and stable, and 3 trajectories for adaptive functioning. Now, one interesting thing is it's not the same kids. So the kids who are dropping their autism symptoms are not the kids necessarily in the higher functioning, adaptive functioning trajectory. You can have all kinds of combinations of kids that are mixed between the trajectories of ADOS severity and the trajectory of adaptive functioning over time. These developmental domains, these outcomes, are not yoked. They don't travel together. It's different kids. This shows what happens when the kids are 6 years of age, and do the kids at 6 in the different trajectories vary in their IQ scores, their language scores, these 3 domains from the Autism Diagnostic Interview, these 2 domains from the CBCL. And you can see that on the symptom severity trajectories, those 2 trajectories differ on these correlates at 6 years of age. And for adaptive functioning, the 3 trajectories differ on these correlates, all but repetitive behaviors that don't seem to differentiate the trajectory groups at 6 years of age. So, to summarize, the results from study 1 suggest that different kids with ASD follow different developmental trajectories in symptom severity and in adaptive functioning. And that this heterogeneity within ASD is not a static function. Heterogeneity increases over time. It's like they're fanning out, as it were, on their individual developmental trajectories. There's some degree of overlap, but it's really a very small amount of yoking. And these trajectories appear to have construct validity in that the outcomes of the trajectories, at least at 6 years of age, are different depending on what trajectory you're in. But what this analysis shows, this heterogeneity trajectory analysis shows that there is a group of children with ASD who do well on either the ADOS or the Vineland or both. And it's only by assuming heterogeneity that you really uncover a group of kids who are doing well. Those who are losing their symptoms, those who are in the improving adaptive functioning trajectory. But then you start to think about the kids who are doing well, and there are some important implications. So one is, I think the concept of higher and lower functioning ASD doesn't make any sense, because there's no necessary correlation between your trajectory in functioning and your trajectory in symptoms. So the idea that higher and lower functioning have more or less symptoms just doesn't really hold water. I didn't show this, but I can tell you that the type of service provided at baseline in Canada doesn't influence the trajectory that the kids are on. The most important predictor of which trajectory a child follows is their baseline score. That is, how they're doing at the beginning, which I think has some implications about, do we really need interventions before the diagnosis. Now, diagnosis is the gatekeeper to getting an intervention. And if the baseline score is so important, maybe we need to be putting more effort into getting the baseline scores of children who are, quote, at risk higher so that they're launched onto a better developmental trajectory. And clearly, the more you think about heterogeneity and how different these kids are, the more you realize the need that we really require individualized early intervention that's fits their developmental trajectory. It's no use giving kids from the 2 or 3 different trajectories the same intervention because they're unlikely to respond to the same degree or even need the same intervention. But as I say, thinking about heterogeneity, assuming heterogeneity within ASD uncovers this group who do well. And you start to wonder about who are the children with ASD who do well, who have a good outcome. What are the outcome domains, actually, that we should be using to think about good outcomes? What does it mean to do well? How does it define it? Most important, who gets to define what a good outcome is? And does doing well at 6, which is what we were able to show, actually is that stable? Is it a stable characteristic? Does it have an impact on outcome later in life? So now I'm going to turn to some of these questions about what a good outcome is in later childhood at 8 to 11 years of age. Okay, how do we define doing well or having a good outcome? It's not actually immediately obvious what it means. Julie Taylor, in a nice editorial in Autism Research, talked about 2 possible ways of defining good outcomes. One is to think of proficiency. That is, a child would reach a certain level of competence regardless of their baseline starting point. Or 2, you can also think of doing well as growth. That is, has there been an improvement over time on a particular important developmental phenotype or developmental domain? So we've got proficiency. Do you reach a certain level of competence? Versus growth, which does depend on the baseline. Do you show improvement over time? So, but still there's issue about what outcome domains do we use? And because Pathways is so influenced by parent input, we held focus groups with parents across the 5 sites to ask them, what are the outcomes that are important to you if we're going to think about if we're going to think about good outcomes or doing well? And parents pretty consistently across the 5 sites talked about communication skills, social skills, independent living skills, physical health, having good emotional health, good educational competence, so success at schools. Again, we were really surprised that a good outcome does not depend on ASD symptom level. Parents did not identify having a lot of ASD symptoms as ruling out what would a good outcome might be, which I think is really important and really interesting. So we use these domains, some of them anyway, to define a good outcome. We're talking now, the kids are 8 to 11 years of age. This is 2 to 4 years of age at inception. We're measuring their communication skills by the Vineland, socialization, social skills, again by the Vineland, activities of daily living. Emotional health, we're measuring with the CBCL, internalizing and externalizing. And we're going to look at correlates of these good outcomes, again looking at the ADOS, their WISC scores, and the number of friendships that they have at 8 to 11 years of age. And we want to define good outcomes in these 5 domains according to a growth criterion and according to a proficiency criterion. And proficiency is when they score in the typical range. So that's a standard score on the Vineland of 85 or more. So that's like 84% of the general, typical population are scoring at that level. If our ASD kids are scoring above that cutoff, we're going to call that proficient. We're going to call growth, a growth outcome, as an improvement in 1 standard deviation in their standard scores over time. So that's a pretty big change over time in their standard scores, not their raw scores now over time. Now, the first thing that we looked at was what's the agreement between proficiency and growth on these 5 domains? In other words, is it the same kids who are proficient in those domains? Are they also the same kids who show significant improvement over time? And the answer is no. There is no agreement beyond chance. That's what kappa measures. There's no agreement beyond chance, those kids who attain proficiency and those kids who show significant growth. They're 2 different groups of kids, by and large. So this is the prevalence of a good outcome by either growth or proficiency in the 5 different domains. So you could have, have a good outcome by both proficiency and growth, that's that bar. By proficiency only, that's that bar. By growth only, that's that bar. Or neither proficiency and growth, that's the light blue bar. So, in general, roughly speaking, between 4 and 10% of the kids have a good outcome by the growth criterion on at least one of the 5 domains. Between 11 and 23% have a good outcome by proficiency only, and 8 to 26% reach a good outcome by both proficiency and growth. So this is another way of sort of talking about the prevalence of proficiency and growth. You can be proficient but not have growth, growth but not proficient, and neither. And this is just the prevalence of this. What strikes me, is that actually that's way better than I would have thought, given what's in the literature, what's talked about, generally speaking. It's lowest on their social skills, for sure, but, their mental health, is a lot of the kids are showing improvement, or they're below average on their externalizing, below average on internalizing, and so forth. So, by and large, individually, there are a good number of kids who are doing well. We can add the different outcomes together, right? So we've got 5 different domains. You can put them all together, and this sort of gives you the frequency of good outcomes in multiple domains. This is the number of kids who have a good outcome across all 5 domains. The number in 4, 3, 2, 1, 0. Just to summarize this, roughly a third have a good outcome by either growth or proficiency in 3 or more domains. So a third of the kids are doing well in 3 or more of the 5 domains. And I'm going to call that a global measure of good outcome. So just hold on to that for a sec. 57% have a good outcome on 2 or more domains. Only 20% have 0 good outcomes on all 5 domains, right? So again, a minority of kids are not showing either growth or improvement in at least one of the 5 different domains. This shows the correlates of a good outcome by domain. So in other words, if you have a good outcome on communication at 8 to 11 years of age, what's your ADOS like? What WISC? What's your friendship? So kids with a good outcome on the communication have lower ADOS scores, have higher WISC scores, no difference in friendships than kids without a good outcome on communication. Daily living skills, having a good outcome on daily living skills doesn't seem to correlate with those other measures at 8 to 11 years of age. Having a good outcome on the social domain certainly means you've got lower ADOS scores, higher WISC, more friendships. The internalizing, only with higher friendships. Externalizing, no correlates. If you have that global measure of good outcome, so 3 good outcomes in the 3 of the 5 domains, you're also lower ADOS scores, higher WISC scores, and more friendships. So again, to me, this speaks to that there is some clinical significance to these measures of good outcomes that we're talking about in the way we've defined it. This slide looks at the predictors of good outcomes. I'm only going to show the global good outcome measure. So kids that have 3 or more good outcomes at 11 years of age. And this looks at time 1 predictors, 2 to 4 years of age. Their SES, ethnicity, sex, service use, Merrill-Palmer, their cognitive scores, language scores, a measure of parent coping, and a measure of family functioning. And the bottom line of this slide is that the only variable to reach statistical significance is the measure of family functioning. So better family functioning at baseline, at 2 to 4 years of age, was the only predictor of having 3 or more good outcomes at 8 to 11 years of age. It emphasizes, I think, the importance of us studying and looking at contextual variables in the, as predictors of important outcomes. Okay, so some clinical and policy implications from the discussion about good outcomes. Having a good outcome that is scoring in the typical range or showing substantial improvement is not uncommon in a representative sample of kids with ASD by late childhood. But it's important to remember that a kid can have a good outcome in one domain, but not another. And you can have a good outcome in one metric, that is growth, and not in proficiency necessarily. So this whole notion about good outcomes, in fact, is quite heterogeneous. These different definitions of a good outcome are associated with other positive aspects of a child's life, such as having more friends, higher IQ, fewer autistic symptoms, etc. And most surprisingly of all, to me, to our group, is that family functioning in the preschool years appears to be a really important predictor of global good outcomes by the time a child is 8 to 11 years of age. It's the first time I've shown these data. Nobody's ever seen them before. You're the first audience, so just causing a lot of thinking and what next steps are. A big issue is whether these findings are stable into adolescence and emerging adulthood. Maybe doing well is not a stable characteristic of kids with ASD. Maybe they do well at one developmental stage and not another. We need to be prepared to think about that. And we have to look at other outcome domains like physical health and educational success, which parents had identified as important developmental domains. Really have to try and understand the means by which family functioning is a predictor of good global outcomes. What is it about family? What is it that families who are functioning well are doing in order to have that associated with good outcomes by 8 to 11 years of age? It must have something to do with accessing services, but we need to really study that in more detail, and we need to translate that into targets for randomized controlled trial. And I think most importantly, we have to ask the youth with ASD themselves, what do they consider to be a good outcome and how we should define it. We've only taken one perspective, which is the perspective of parents, which is very important, but we also have to challenge our definition of what a good outcome is, the domains that we use, the cutoffs that we use, the criteria. We need to challenge ourselves and ask kids with ASD themselves what they think and what they would consider, and see if we can look at our data with that in mind. This brings me to the idea, however, of the notion of core outcome sets. And this is a topic that's broader than ASD, but actually encompasses all of health. A core outcome set refers to the minimal set of outcomes that should be measured in a standardized way in all clinical trials and in longitudinal cohort studies. I don't know how many of you have tried to do a systematic review or have tried to do a meta-analysis, and you're stymied by the fact that all the clinical trials use different outcome measures. It's nuts. And if you think that by aggregating those, by just calculating their effect size, that you're getting a homogeneous estimate of treatment effects using these standardized coefficients, it's nuts. You're crazy. Sorry. Sorry to let you know. So the development of core outcome sets is an attempt to get the entire field together and agree on what are the outcomes that we should be measuring and how should we be measuring them. It started in rheumatology. It's moved to diabetes, cardiovascular disease. It has not moved to mental health. It needs to be moved to the ASD field as well. Developing a core outcome set is based on a synthesis of systematic reviews and, most importantly, stakeholder input. Again, you have to have, for us, parents and people with ASD involved in defining what a core outcome set would be and how we should measure it. And I would argue as well that the core outcome sets that we use to measure clinical trials and longitudinal studies, we should also be using in clinical practice. That's what we should be using to determine the clinical progress of our kids, of our clients. Standardize our definition of outcome measurement and set targets for the achievement of those targets in a particular domain. What I'm really talking about is the concept of measurement-based care, which needs to be brought to the field of ASD. And the second topic I wanted to bring up that I've been thinking a lot about in the context of ASD is the notion of resilience. Can kids with ASD be resilient? So resilience usually refers to individuals who have better than expected outcomes in the face of adversity. The adversity, however, is usually an external event, some kind of natural disaster, a trauma, a catastrophe, mental illness in a parent. I don't know, but resilience in ASD really could be considered achieving a good outcome in key domains, defined really by this notion of core outcome sets. But if you look in PubMed, there's not a single publication in PubMed on resiliency in ASD. People talk about parents being resilient to the birth of a child with ASD, but there is no discussion in the literature whatsoever about kids with ASD themselves being resilient. And that, to me, seems to be a really important blind spot. I'd be interested in your thoughts about that issue. I just want to acknowledge the Pathways in ASD team that supported all the work. Catherine Cost, my research associate, worked on these data with me really hard. There is the study team that worked together for many years, and of course all the children and families who have participated in the study. So thank you very much.